Let me introduce our speaker in this series of distinguished addresses. Dr. Tony George, experienced professor of psychology, got a long background in this arena, strong educational profession, with a PhD focused on group psychotherapy. Also, Dr. George is a practicing psychotherapist and is involved in training, research, and clinical practice, Dean of Social Sciences, Head of Psychology Department, and supports the Center for Research at Christ University, Bangalore, in India. Also, he was the founding director of the Center for Academic and Professional Support, and a whole of other experience besides. And it's with absolute delight that I'll now hand the mic over. And yeah, just celebrate the fact that we're already beginning to live our values with hearing voices from around the world, not just in the global north. Thank you.
Hari, thank you for that introduction. Good to be here. It's night for us here in India. I think it's evening in the UK and other places that you've logged in from. Thank you for this opportunity to share some thoughts with you this evening on the discourse that the website Decolpsych has initiated on decolonizing mental health training and service delivery in India. I've titled this talk this evening as Navigating India's Psyche Through Gaps in Mental Health Resource and Access, because as I look back at years of work in mental health training in India, there are two words that keep coming up. One is navigation and the other is negotiation. I think discourses in decolonizing of mental health, whether it's training or service delivery, is a series of negotiations and navigations that all of us as mental health professionals and those interested in mental health delivery are part of. And for some time, I've held a rather tenacious position when it comes to decolonizing. And I've softened up a lot over the years because I know that it's easy to speak about decolonizing mental health service and training, but it's really hard to live our lives through that. And so through the presentation and reflection this evening, I'd like the audience here to reflect on these two words, navigation and negotiation. And what I will do today is share some of my experiences and reflections on how we in India as a mental health fraternity have made some of these navigations and negotiations by taking some instances in mind. I'd also like to remind us, as Hari did during the introduction, that discourses on decolonization perhaps needs to be seen through a lens of care, of healing, within a socially just and equitable frame. It's really hard to engage with decolonizing narratives in mental health if we lose sight of what all of us here in this room and others who are interested in decolonizing narratives really look forward to. And that's the care of those who have challenges with mental health, mental wellness, and so on. And so that's a larger framework in which we will talk today and converse today about mental health and decolonizing experience. I spend a lot of my time living outside India. I was born in east of Africa and then moved to the west of Africa for many years. I've heard my parents speak about family members who've had mental health concerns. And I remember as a growing up child, when I heard that one of my cousins suffers from schizophrenia and is taking medication in a hospital, I used to ask my parents, why not just pray and, things will, get better. Because I was brought up in a Judeo-Christian ethic where there was great belief in the power of God to change people's lives. But as I began my training in mental health, I realized that the interface between religion, culture, belief, mental health, science, and so on is far more complex than we assume it to be. And I think those are the challenges that we continue to face in decolonizing narratives. I remember some of my earlier impressions of mental health and culture in one of the countries that I grew up in was about torture, was related to torture. And that was difficult. Persons with mental health were often tortured. Sometimes in the criminal justice system, justice in courts, you would actually place nail onto your forehead and then, hit that into your skull as a method of both punishment and a method of containing mental health challenges. And I'm sure that all of us have grown up with stories, personal stories and narratives of mental health, and we have a personal connection to mental health. And I think that's the core of decolonizing narratives as well. Some of the largest mistakes that we have done in India is neglecting the personal beliefs and the cultural rootedness of those who we consider as needing mental health services. And when I speak a little later about the failures of community mental health in India, I'll speak a little bit more about that. My reflection today is going to be around a series of negotiations. We will look at community mental health in India. India has one of the longest traditions of community mental health compared to different parts of the world. I'll speak a little bit about indigenous healing, about experiences with faith healers, temple healing, and other faith healing experiences in India. And I'll probably connect most of that to curriculum of mental health training, because a lot of what I do today is training and education and partly direct service delivery. Hari, how's the voice and how's the clarity and all that? It's fine, all right. When I started my training in mental health, I used to love going to the community. And you see, there's a problem with that statement, because the moment we say we are going to the community, it assumes that the community is out there and we are here. And we were the mental health team. And we really did go to the community, because we would all pack ourselves up in a van, and then we would drive for a couple of hours, and then we would reach the community. And then we would dispense mental health services. And then we would come back. And that was it. I think community mental health in India for a long time has looked at community as an object of intervention and not as a partner of intervention. And the mental health team, in many ways, has inherited a colonial psychiatric model, which in itself becomes hegemonic. And the dynamic voices of those in the community hardly emerged in community mental health interventions. The World Health Organization was a dominant part of establishing community mental health in India. And the World Health Organization, the voices of psychiatrists and psychologists, sometimes a symbol of power, and has moved community mental health in a direction that perhaps has taken us away from the real meaning of community. There were hardly any ethnographic research done in communities in India before testing of models of community mental health. I'll speak specifically about two community mental health projects that were run in India. One is called the Sakalwara project, which is quite close to where I live and where it was run by the institution where I was trained in, which is the National Institute of Mental Health and Neurosciences. The Sakalwara project was a project, an intervention of a major mental health facility in Bangalore. And it was sponsored by local political teams, and it sustained over the years. A mental health facility was set up in the community, a couple of kilometers away from Bangalore, and mental health workers were appointed there to provide treatment to persons from the community. It was pretty much the medical model, and there was very less interface with the community. But there was something about that model that stands out. And when I speak about decolonizing narratives, I think it's important for us to recognize that we should not fall into the trap of the binary of the good and the bad, because there is a lot that we have gained in India in the promotion of mental health that we have gained from models in the West and other places. And so I'm always careful about, holding a black and white position when it comes to speaking about Western models of care. Now, the Sakalvara project was very effective because part of that project partnered with local faith healers. All of us know that first line of pathway to care for mental health in most countries, especially low middle income countries, are faith healers, local community, and so on. And the mental health professional is perhaps 2 or 3 spaces away from reaching out. And relapse rates were high, mental health morbidity was high. Psychiatrists joined forces with faith healers and worked together in the Sakalvara project. And faith healers were given primary education in psychiatry and psychology. That was a good thing and also a bad thing, because the reverse did not happen. Psychiatrists and psychologists and social workers did not get educated about faith healing practices. That's been a big problem in community mental health in India. It's always been unidirectional from the mental health practitioners and educators to the community, and not the other way around. And I think that's a challenge that we're still facing. We continue to transmit that colonial heritage in classroom teaching as well. The other advantage of the Sakalvara project that it was locally, sponsored by local political parties, and so it sustained for a period of time. As you and I know, political agendas can soon become part of, mental health delivery. The second project that I would like to speak to you about is called the Raipur project. Right at the bottom of the slide, I've mentioned the 2 projects. That's the northern part of India. That was sponsored by the World Health Organization. The Raipur project, the strength of the Raipur project was that it looked at evaluation and testing of models. It established a very Eurocentric mental health model in communities in northern part of India, and then tested for its, effectiveness in the community. A major flaw with both projects was the way in which the term community was constructed, framed as peripheral and underdeveloped and in need of services and education. Villages were represented in highly factual and asocial terms, almost removing the essence and the richness of a community away from the community, and then approach, the villages as in need of services. There's also been a more inherent struggle in community mental health in India, especially when it comes to linking of modern psychiatry to traditional Indian knowledge. Many senior Indian psychiatrists privilege classical indigenous medical systems and Hindu texts over folk healing traditions. I will demonstrate in a little while how complex India is. And within the community mental health movement, and within the indigenization of, mental health systems, there's also hegemonic practices. And it's hard to blame or place blame on European colonial powers. These are practices that have emerged from within the country itself. And so it's, I think, useful for us in India to ask this question: who is colonizing? On the one hand, colonization literature has focused on how colonization by mainly European and Western colonial powers have impacted the psyche and the working in communities in, countries like India. But I think it's also important for us to ask questions about who is otherwise colonizing. And I think for those of us who work in India, those who work within educational systems and healthcare systems, this question is becoming increasingly. I will demonstrate a little later a model that looks at how folk healing traditions in India responds to mental health names. I'm going to pause for a couple of seconds. Today in higher education and in the delivery of higher education in India, there is a pressure to introduce what is known as indigenous knowledge systems or Indian knowledge systems. But there's hardly any question about what Indian knowledge systems actually mean. Because I think that takes us to a question of what India is. And that's an important question for us to. India is pretty complex. For those of you who live in India and who've traveled to India, just a couple of kilometers away from where I live, I might as well be in a different country because I don't know the language and I don't understand the culture. And I feel pretty much like a tourist, like a foreigner. India is so complex with perhaps recorded 780 languages, but if you look at dialects as well, it's much more, maybe 4,000 or more dialects spoken in different parts of India. Major world religions, much more than what you see here from the Wikipedia screenshots that I placed for you here, and so on. Just these two data points, tells us about the diversity within a country like India. And so to speak about indigenous traditions, folk traditions, tribal traditions, and so on, there can be no homogeneity. The problem in India today, the past that we've inherited from our colonial history, and the present that we're living from the histories that we have created within the country, emphasizes a sense of homogeneity. But India is far from any sort of homogeneity. For those of us interested in community mental health, 69% of India is still rural, and 30%, 31% is urban. Yet, training in mental health delivery is largely focused on Western models among urban groups. While the rural community, for instance, is more likely to experience depression compared to the urban, there are hardly any forms or models developed to understand mental health experiences in rural India. We know for sure that education, caste status, IADL, perceived discrimination, political hegemony are factors contributing to poor mental well-being. In India, farmer suicide has been a big challenge. And suicides among farmers happen because of economic disparities and political disparities, and not because of mental health conditions. Western literature on suicide prevalence has a tendency to link suicide to mental health conditions like depression, but not so in India. You don't have to have a clinical history of depression to commit suicide. It's often economic factors or huge challenges in your psychosocial world. India is far too complex for us to apply any one form of community mental health model or to talk about indigenous models that can be understood similarly across the country. And this complexity is something that I think mental health practitioners and educators need to constantly reflect. Look, the initial community mental health projects in India were located within the caste, patriarchy, and matriarchy gender dynamic of the powerful and the powerless. It was superimposed on these dynamics, which meant that none of these dynamics were really considered when mental health, services were delivered. That, as you and I know, can be extremely challenging and difficult. A lot of mental health indices in India are directly linked to our own position within the social strata of the country, the caste dynamic of the country, and so on. A number of researchers who are looking at masculinity and mental health and well-being, and looking at it through lenses that are still located within some of these dynamics. The dynamic of the powerful and the powerless, for instance. Even within community mental health programs in India, local communities that have access and affluence and influence have received better care when it comes to those who do not. And so the barriers still continue within the communities. I want to shift gears now, having spoken a little bit about the challenges in community mental health in India. I want to shift gears a little bit and speak about faith healing. The British Medical Journal published an article from India in, I think it was 2002, on traditional community resources for mental health, a report of temple healing from India. The British Medical Journal is very conservative, as many of you know. You need to get hard data in if you want to be seen and reported. Aside of the politics of publication, which I think requires a separate conversation, the British Medical Journal published this work on temple healing in India. What you see on the screen is the summary points from the article. And what this article and the work that colleagues from the National Institute of Mental Health and Neurosciences did showed that temples served as spaces where persons received psychotherapeutic support. And they used a rating scale to look at changes in mental health distress. I think that's why it got published, because of the rating scale. The research showed that if you have a brief stay at one of the healing temples in South India, in a state called Tamil Nadu, it improved objective measures of clinical psychology. There was no particular healing ritual. It was a place to come and stay, and it was a supportive, non-therapeutic environment. What classical, mental health professionals might call as non-specific factors and so on. But what was interesting is that the community was able to provide healing persons who needed that. That has been true of faith healing systems in India. None of this is taught in mental health education. There's hardly any field visit by students who learn about mental health to faith healing centers, and there's no discussion and there's no conversation. So there's really no negotiation taking place. So there's no way in which we have made connections with these realities. However, I also want to point out that faith healing can go wrong. The picture that you see in the PowerPoint is actually from a well-known tragedy that happened in 2001. It's called the Irwadi fire tragedy. And this happened at a dargah in, again, I think in Tamil Nadu, where a number of persons who were tied and chained in this particular religious center died because there was a fire that broke out and they couldn't escape. And then the Mental Health Commission went into action and did an investigation and brought out some more rules and policies, which in fact distanced faith healing from mental health community. There's always something to learn and there's always something to take back, but there are also challenges that we face when it comes to faith healing. I don't think there's been ever enough discourse between mental health professionals and faith healers, enough for us to work better towards the delivery of healthcare resources. Today, despite challenges like the Irwadi fire, most uh, most of our clients and patients, or those who experience mental health challenges, still go to faith healers, and local resources before coming to mental health facilities. And so I think it's important to negotiate some of these challenges, and also to take mental health education to local centers. Most mental health education in India, whether it's psychiatry, psychology, counseling psychology, social work, to some extent, happens within classrooms or within urban centers, where the medical and biological model is the most dominant model. And so we are fairly distanced in our lives from what local communities can offer. I think indigenous resources and systems of care, therefore, do not feature much in training of psychiatry and psychology. I started this slide by saying a very cliched statement in decolonizing narratives that the influence of Western models of care have led to marginalization of systems in mental health training and service integration. And I stopped myself. I thought maybe, hey, before you start, talking about Western models marginalizing us, let's speak about perhaps what we have not been doing to counter some of these challenges. And I think what we have not been doing is we've not been bringing indigenous resources and systems of care into the classrooms, me included. I know in the institution that I work, we hardly have discourses about decolonization of mental health. Hardly anything. When I visit South Africa, for instance, I know that my colleagues there have written textbooks based on decolonization narratives and so on. But we haven't done enough in India. There's a long way to go. And I think it needs to start with us. It's sometimes very useful to critique Western models of care, and we will do that anyway. But I think it's also important for us to think about what we're not doing enough to counter and to bring some of the indigenous resources into mainstream education. I think we sometimes have an elective called Asian healing practices, and a couple of students who have some interest in looking at their own roots take that. But I think those should be core courses in our curriculum, because that's one way of helping us to reconnect with roots and cultures that we have, separated ourselves from. I think decolonial discourse has not entered into Indian academia much. And so we are at maybe infancy stage when it comes to how our curriculum is, created. And it's often spoken as a binary disconnect experience. So you go to a classroom lecture and say, here's a Western model and here's the Indian model, but that's a binary. It's a highly disconnected experience because many of us as professors and even students live disconnected lives. If we talk about a visit to a rural community in the classroom as part of a program, you'll have half the students in the class saying we don't want to go. And I think that's reflection of how disconnected our lives can be. Most of our curricula is scanty, it's compartmentalized. Psychiatry, psychology, social work, nursing, counseling, psychology practices have provided perhaps a very cursory treatment and sometimes a choice. But here's an example of, I think, a counter to what I've been saying so far. A university in India that's crafting a curriculum in indigenous and tribal communities. And here are some of the things that I think they've done right. It's been their approach has not started with mental health professionals saying what they have to do, but with grounded ethnographic work among the communities, listening to the voices of the community and getting them on board to speak what wellness and mental health means. That's a starting point. I think that's a useful starting point because we now then know what the community is. So far, we were only visiting the community like a tourist, but we now know what community means and we can learn from that. we can suspend some of our lenses. Tribal psychology curriculum established by this university in northeastern part of India, for instance, has units such as health-seeking behavior, tribal way of life and well-being, traditional food, cultural syndrome, holistic healing, traditional health practices, resilience and wellness as important parts of the curriculum. And this is not true just for tribal psychology. There can be several psychologies in India. The scheduled castes in India, the Brahmins, the urban, there's several worldviews and psychologies that are not addressed in mental health training and so on. This is a great example of how India is looking at considering indigenous knowledge into mental health curriculum. I think we need to do a lot more of that. I also want to speak a little bit about what training can do with, or what we can do with training. Perhaps it should be what we can do with training. I think training in mental health in India require more context to examine cultural blind spots. And there isn't enough measured and thoughtful critique of mental health and wellness. There is critique, but sometimes the critique is rather infantile and impulsive. There is a critique in the classroom against biomedical models, for instance, completely negating the value of biological factors in mental health when it's important. And so the framework that is used in classrooms tend to be very black and white. There is advocacy without knowledge. Most of our classrooms, students spend a lot of time talking about mental health needs, and so on, advocating for mental health, but perhaps not balanced with sufficient knowledge about mental health dynamics. And that's a challenge. And I think that's a challenge in the interface of both Western and Eastern models of mental health training. There's hardly any ethnography taught in classrooms today, because if you really want to understand what communities and stakeholders and what voices mean, it's high time that we stopped measuring. And it's important for us to take a step back and listen, and then try and understand what the community is telling us. And that, I think, our training needs that a lot. I also want to share with you a thought about what's happened after colonization. India received independence in 1947, and subsequently there have been several, as a result of the British rule in India, there have been a lot of instability in India, especially in terms of state formation and about realignments and so on and so forth. And one of the challenges that mental health services and frameworks have not really captured India's intergenerational trauma. I think the next talk in the series is on intergenerational trauma. This is an example of how in one of the states in India, northeastern part of India, is a state called Mizoram. Maybe I will go back to the map here. So where is Mizoram? Can you see my cursor? Is my cursor visible? All right, yeah, okay. You see that here, Mizoram? It's really close to Myanmar and Bangladesh. There's two other countries. So India has a strip here right at the top. And this is called the northeastern part of India, very close to Tibet, China over here. You can see that, right? So there was insurgency in Mizoram. And what happened in the 1970s, a little before that, is that there were several of the men lost their lives and the women were left alone. And the witnesses trauma firsthand. It was transmitted from generation to generation. A colleague of mine and I looked at how intergenerational trauma is transmitted and is never understood in mainstream, psychiatric conceptualizations of depression, post-traumatic stress, so on and so forth. And the ambiguous losses that we face due to the larger political and national instability is then passed on from a generation to the other. The northeastern part of India has a number of psychiatric facilities. Several of them function using Western models of care and have been highly ineffective because they failed to grasp some of the subtle and nuanced challenges that persons go through. I think in mental health delivery in India, if we are speaking about decolonizing experiences, it's important to look at intergenerational trauma as impacted by political national instability, which in itself is a remnant of the colonial system, but is also continued to be perpetuated by dominant forces in India. Let's take a peek into the therapy room in India. Those of us who practice relationship-oriented therapies and so on have often confronted the challenge of working with family systems. Relationships in India are complex. Some of the Western notions of boundaries, for instance, does not work. We've had women who live in abusive relationships in local communities, and there is no way in which boundaries are going to work. It's really hard. Everybody feels helpless. Red flags, looking for red flags in relationships sometimes do not make sense in communities where the oppressed sometimes needs the oppressor. And this is sad, isn't it? Because it defeats the notions of social justice. And it's hard for mental health professionals to see some of these complex relationships in the therapy room and then yet feel helpless, because you know that there is nothing much we can do to change some of the larger dynamics around which people live. And so we'll have to learn how to negotiate there and look at how systemic injustices can actually be addressed in a larger level if there has to be a change in the presentations in the therapy room, and if empowerment can actually take place. We've had clients who come to the therapy room and that's the only safe space they have. And there are no other safe spaces that we can create. There's no environmental manipulation possible. There is no policy possible. I remember a young child that we were working with years ago, and we used a child helpline system that exists in India, like in several other countries in the West. It's a child protection service. And so she was removed from the home and she was placed in an institution for children. And she suffered much greater harm in that institution. And she wrote a postcard to the treating team and said, my life was bad, but you've made it worse now. Thank you for doing that. And it's hard for a mental health team to receive messages like that, because it reminds you that policies are not enough. They might look great on paper, but they really don't work when systemic injustices are not dealt with. There's, in terms of access, digital mental health is now being promoted in India. If India is so diverse and access is hard because of the huge rural-urban divide and so on and so forth, why not get mental health right into the homes through devices, television, and so on? It's a huge project of the government of India, and it has its benefits. But it also asks us questions about what is being transmitted through digital mental health to Indian homes, and what is the messages that they're receiving. A lot of digital mental health interventions in India do not consider cultural nuances of the communities where messages reach. And so the barriers continue to exist. Clients will continue to ask us if it's really because of, the conventional psychiatric explanations. And they will counter that. While digital mental health has served to bring mental health education to places in India which did not have that, cultural belief systems have not been adequately addressed. So we have clients asking or telling us that the mental health that you are talking about is really a curse from God and we want to live with it. Or the mental health that you're talking about is really a function of a sin that we've committed in a past life. And I don't think that what you are promoting here is going to make a difference. And so again, we're faced with this difficulty of not having negotiated enough. We know that in the future, artificial intelligence is not in the future, it's already making a big difference in mental health care and delivery. A colleague of mine recently told me that a client was requested to make a reflection of how the session went, and the client used ChatGPT to do that and brought it back to the therapist, and so on. That's interesting, isn't it? How artificial intelligence and human-computer interface kind of changes our lives. One of the biggest problems with artificial intelligence, perhaps, that we will see is the cultural bias that is inbuilt within the algorithms. And a lot of data sets that are used by AI systems in mental health are Western data sets. So the challenges that we've been speaking about so far are likely to seep into digital mental health itself. But I think the digital mental health in India is a great vehicle for bringing mental health to the doorstep of people who haven't. I'll just speak a couple of other thoughts, and I'll close within 1 or 2 minutes and then open it up for some thoughts. I've placed a couple of sentences here. The first is activism without mind, and I want to speak about an experience we had recently at the Center for Neurodiversity. India, as you know, is very complex, and everybody has an opinion today about how people are and how people should be. Perhaps all of us included, right? And on social media, when we spoke about certain forms of disability and challenge that people were going through, a portion of social media began to very strongly oppose that model. And then we heard voices of parents who are living day in and day out with children who have disability. And their voices were very different from the voices in social media. There's always a great divide between people who have both experience and knowledge versus persons who have only experience and persons who have no knowledge. I think this is a challenge of how, social media might influence mental health and understanding of mental health. A large proportion of young people, and no ageist bias intended here, today will speak forthrightly about the importance of mental health, but will do hardly anything about taking care of their mental health. This is an example of what I mean, activism without mind. Today, family systems in India have considerably changed. Mature voices that can guide people to take care of themselves are less. And some of these factors have led to narratives about mental health, but hardly initiatives where you can take control of mental health and well-being. So the balance between knowledge and voice is, a balance that we'll need to bring back into mental health. We've seen a lot of migration and reverse migration in India. A lot of cities in India have seen reverse migration, especially expatriates who lived outside of India have come back to India. And one of the benefits or blessings of reverse migration has been employee assistantship programs in workplaces. But we can critique employee assistantship programs as well, because they're developed in countries where insurance and hospital management organizations, as well as human resource departments, paid for mental health service. And you can't pay a lot for mental health in most countries. Right? Insurance is very clever and smart. And so you might get 5 sessions. So if you have a mental health challenge, you're entitled to five free sessions on behalf of the organization. And then you're on your own. And it's really hard to do much in 5 sessions. And I think that's a problem with employee assistantship programs. That I think also is a colonial heritage. It's a heritage of capitalism. It's an offshoot of colonialism. But migration has also brought in a lot of mental health awareness in India, especially those who live in urban cities are much better today at identifying mental health challenges and looking for mental health service. And so that's, I think, positive. I want to conclude with, especially for those of us who are part of higher education and mental health educators, 3 experiences that we've had at the university where I work. One was a project with a university in the United States called the Partnership 2020 Project, Global Health and Economic Disparities Project. And this project brought together students from the United States and students from India to work together on common health challenges faced by individuals in both countries. And this meant a lot of sharing of information, resources, and experience, and getting into uncomfortable spaces, because it actually meant making visits to rural communities and spaces that they would not have otherwise gone and visited, and then talking to each other about it. I think this is a great experience to bridge and navigate some of the challenges that we otherwise grapple with. And higher education institutions can actually create opportunities for greater discourse. Maybe Decolpsych can perhaps think about connecting mental health, students of mental health from across cultures, to really talk to each other and talk about challenges they face. The second experiment, which I found really helpful, was a grant writing opportunity for students. The students in the United States wrote grant projects for challenges in India, challenges that are influenced by social inequities, marginalized groups, and so on. And while writing these grants, they got an opportunity to interview, talk, and understand those realities. And these were transformative experiences. I think this is a great way for the East and the West to talk to each other. We've also had a very respectful discussion about curriculum. In higher education curriculum, one of the legacies of colonialism is that Indian curriculum developers always look to the West as a benchmark. You hardly look at other places. So when you look at the West as a benchmark, what you're actually doing, aside of the good things, aside of evidence-based practices and so many other great things that we can learn from the West, we're also in some sense, absorbing colonial frameworks into a curriculum. But the exercise that we did here was a cross-critiquing of curriculum. Colleagues from the West looked at curriculum that we offer, and we looked at the curriculum that they offered, and then critiqued these curricula using our own lenses. That was helpful. And I think that bidirectional movement of critique, again, I think negotiates better, or is a better negotiation of the decolonial experiences that all of us go through. So I'm going to stop here with these thoughts of mine as an educator of mental health over the years and partly service provider, and perhaps stop and then hand it back to Hari for perhaps questions or discussions, or maybe some additional comments for those of you, and many of you here in this webinar have a lot of experience to offer in this field.
Fabulous. Thank you so much, Tony, for a deeply insightful, and I kind of think also the way in which you hinted to so many things, we could like spend another hour unpicking and unpacking so many of the concepts. So I want to open it up. I've got so many kind of questions and thoughts and reflections, but I don't want to just kind of jump in and use the space. So if there's anyone else who has a question or something you want to ask, please feel free, just pop up your hand digitally and we'll respond. Maybe we can stop sharing now, and then we can get, so Rachel.
Thank you, Tony, for a really thorough, comprehensive talk. I agree with Harry. I've got so many questions to ask. I've got a list here, but I'm not going to be greedy. I'm just going to ask one. When you talked about faith healers, you talked about how they were trained in psychology and psychiatry. And I just wondered, you know, how you might think about there being much more of a bilateral flow, so that faith healers are also informing so-called mental health professionals. I know that's a bit contentious to use that term. And the whole use of kind of health pluralism, where you link the two. Anyway, I'd just like to know your thoughts.
I have a couple of responses in my head. You know, going back to the project that I was talking about, Rachel, the mental health team went into the community and they actually first tried to intervene without the support of faith healers. And they found that it was just not working. Faith healers were seen as barriers to the mental health team going into the community. But I think some kind of wisdom set in, and we decided to talk to the faith healers and acknowledge the position that faith healers held in the community. I think that was critical. What the psychiatry team did was to talk to faith healers a little bit about psychopharmacology and about the difference between psychosis and some of the anxiety conditions and so on. And you know, let them know that, you know, we are on the same page and so on. And the faith healers were quick to, you know, accept that, because what would happen is the clients would go to the faith healers first. Faith healers, with the knowledge that they've gained from the mental health team, would quickly decide whether this person requires additional support. So they would say, okay, I want you to, you know, chant these mantras 3 times a day, but I also want you to meet the gentleman who's sitting over there in that, you know, space there, because he can give you something more to help you. Coming to your question, to make that bilateral, I think what would be helpful in mainstream training of psychiatry and psychology is for students of psychology and psychiatry to make field visits and spend time understanding how faith healers work. I think it's important to encourage students to engage in ethnographic work with faith healers. I don't think it's a great idea to invite faith healers as guest lecturers to come and give a talk in the university. I think that still maintains a certain distance. I've done that and I've seen that being done in several places. It really doesn't work because it still keeps you a lot distant away from it. So I think maybe it's ideal at this point of time, but I think it's helpful to have a summer school perhaps in the community and spend a couple of weeks doing a course in the community. There is a program like this in India, in the northeast of India. There is a summer school for students of mental health to go and spend a month and learn with the community. I think that model works very well for bilateral, you know, learning than any other model that I can think of. For sure, just talking about it in the classroom is not going to happen.
Thank you.
Thank you. Any other questions or contributions as we draw to a close? I'll quickly slip in some of my kind of questions. There was the bit when you were speaking about the potential of the healing temples to bring some kind of healing, and it just brought to mind the 1978 World Health Organization. You kind of, you know, referenced WHO as kind of being in some way like part of the colonial enterprise, but that you know, famous paper in India, Colombia, Nigeria, where, the models of community supported, recovery. What kind of struck me is, I can't do the maths quickly enough, but that was a very long time ago. And we've kind of known this, and it's something when I do my teaching, I always kind of say, people are talking about some of these ideas as though they're brand new, but the World Health Organization was aware of this. And why do you think it is that with the knowledge that there are other ways of supporting people's healing, there's so much resistance against it? And in some way, in my mind, it bookended with your reflection on psychotherapy and forms of therapy that have been bought into the capitalist enterprise. And I kind of just wondered how you saw that relationship with, capitalism in psychiatry, and therefore how it creates a resistance against some of these kind of indigenous approaches.
I think the capitalist argument is perhaps the closest that I can think of when it comes to not bringing some of these experiences which we have known to be true into curriculum, and pushing that to the forefront. You and I know that part of capitalism is larger enterprises like the pharmaceutical industry, job market, insurance, and so on. I think they play a big role directly or indirectly in how curriculum is designed in countries like India, world over, of course. And I think it's also in part, by we're an analytical frame, in part the blind spots that we as practitioners and mental health professionals also bring to the table, because we have not invested enough ourselves in introspecting into our own consciousness about what works and what doesn't work. And in some sense, perhaps we've not been critical enough to bring that into a curriculum. So those are some quick responses, and I think it's surprising that the research from Africa and some of the work from other parts of the world are not in mental health 101 courses even today.
Thank you. I'm really, really mindful when people, I know it's very late in the night for you, Professor, and for our colleagues online in the UK, it's probably time for people to go and get a meal. So though I'd really love to stay in this space, I do want to pull it to a close. I do want to just say one thing by way of closing, and we can kind of correspond with each other, all of us outside of this space. Find me on LinkedIn, on X, and we can kind of keep conversations going. But what's really striking me, I guess it's bringing it to the fore, is the way in which our systems often talk about decolonization as if they can just change the reading list in universities, or they can just kind of put up a few posters and get a few more diverse people in the management tier or in the faculty staff, and then we kind of have begun to decolonize. And I've been saying for a while that it actually means a literal deconstruction of what we've come to recognize as the orthodox of psychiatry, and to begin to behave really differently. And yeah, sometimes I feel really optimistic, and sometimes I think I'm not sure if they're ready for it. But then I hang out with people like you, Tony, and everyone else online, and I think, yeah, maybe if we connect up like we're doing now, we can do it. And that's the energy I close with. Let's keep staying connected. I guess that's the only way. Thank you so much again. And thank you all for joining.